So today with me, I've got Dr. Edward S. Greeley II. He goes by Ted. He has been a physical therapist for about 10 years now. He's currently the clinic director at Riverview Physical Therapy at the Portland Clinic. So that's about the most of the introduction I'm going to do for Ted, because I'm just going to ask him a few questions, just because he's a great friend of mine. But to be honest, like, we don't really talk shop that much, even though we've known each other for a long time. So I just kind of want
2007.
to. What's that?
2007. So
2007. Yeah, we've known each other and been very good friends since 2007. But I'm really looking forward to this today because Teddy has done a lot of continuing education and a lot of training since PT school. And him and I have taken very different routes. We haven't lived really even close to each other during this time since we've graduated, and yet it seems like we've kind of come a little bit closer to a similar type of treatment paradigm. And I'm actually really curious to sort of hear how Teddy's job is doing right now, and kind of how we got here. So Ted, I know you're newly married. Congratulations on that. That's fantastic.
you know it well because you were in the wedding.
I was in the wedding. Yes, I was. But if you can sort of take me through sort of what you've been doing since PT school, and sort of from a professional, and then obviously, all of our stories have sort of a personal part to it as well. Sort of how'd you where'd you sort of start, and where are you at now?
Post-graduation, you're saying?
Yeah, like, because I know you jumped into a lot of different trainings and whatnot, and sort of, how did you sort of like, where'd you sort of see movement in treating people, and then kind of, kind of take me through sort of, your big checkpoints as you are through your development from that point.
So initially, after graduation, when it came to continuing education, I was all over the board. I had no idea what direction to go. There were so many things. It was overwhelming, that I was just taking things that interested me, and nothing was really being tied together. Then the first one I got that kind of started bringing stuff together was when I did the functional movement systems, the initial training that they have, and then eventually did SFMA, selective functional movement assessment. And that kind of brought
I say, can you sort of elaborate on like what that is?
Yeah. So basically, when you're in PT school, you study the shoulder, you study the hip, you study the knee, you study the lower back. Everything is broken up, and there's no real integration of all of it, how it's all connected. It's the, cliche, it's all connected. It truly is. And we'll get to that. But when you're in school, everything is very separate, and if the shoulder's hurt, you treat the shoulder. FMS is a functional movement screen, and basically you take your client, if you're a personal trainer, and you have them go through set movements that are testing the whole body at once. One movement, you might be really looking at the leg, but it's also looking at what the trunk's doing at the same time. So gotcha. Yes, you're screening out the knee because they're there for knee pain, but you're also looking at the quality of how they're moving in their trunk as they're trying to do stepping over a step and touching their heel and coming back. So you're looking at it all. And then the next step in that was the SFMA I mentioned, which was selective functional movement assessment. And that just further breaks it down and gets a little deeper into it. So it's bringing all the systems together, all the joints together, I guess you should say, instead of systems.
Yeah.
And that was kind of, after our first few classes just being random, I looked into a tennis certification, PGA Tour through Titleist certification. And yeah, those are great, but those are very niche and specific. So when I got to the FMS and the SFMA, it really started bringing the whole body together. And then I started going down a manual route, just hands-on techniques, because I felt like we got a lot of that in school, you and I, because we're going to school together. I just wanted more understanding and a little further education in it. So I started going through NIOM, it's called North American Institute of Orthopedic Manual Therapy. Did 7 or 9 courses. It breaks it down.
Yeah, that's a lot.
Yeah, I spent a lot of continuing education money through my previous job.
Yeah.
But it breaks down kind of the neck. Yes, it ties into the rest of the body, but like was really specific to the neck. And I did a thoracic spine, your mid back, and I did a lower back, and I did a lower extremity, upper extremity, and then did the second levels of all of that, and was going to go through their certification program and get certified in their treatment paradigm kind of thing. And then I started noticing how a lot of my patients came in looking very similar in their posture, and I couldn't figure it out. And I started mentioning it to coworkers at a previous job, and they're like, yeah, I kind of see it. And I was just like, it was really perplexing to me. And I left that job and ended up where I'm at now, Riverview Physical Therapy. And during my interview, the owner, Greg Napton, mentioned how he treats this kind of continuing education stuff he follows. And he started saying some of the things that I've been saying to my previous coworkers. And I was like, oh, okay, this is where I need to be. So I came to this job, started learning some of the stuff from him, just like as you can in the clinic, as you're both treating patients. And when you first come to a job, you kind of co-treat. So started picking stuff up from him, and then started going down the actual path of new continuing education through the PRI, Postural Restoration Institute. And that's really the majority of my treatment style now. Kind of my treatment paradigm is going through posture affects everyone. If someone comes in with jaw pain, if they come in with knee pain, big toe, thumb, shoulder, I have to assess their overall posture. And it's not just how you sit at your desk, oh, let's do an ergonomic assessment. No, it's how are they holding themselves when they're sleeping, when they're walking, when they're doing everything. I find that everyone tends to be a little proud in the chest, a little arched in their back. And we need to change that because it affects everything. And so that was really long-winded, but that's how I got to where I'm at now.
No. It's not long-winded. It's good. It's in terms of, what I think, mostly because this podcast is sort of, or this, this sort of media or this content that we're doing right now, sort of geared towards potential, patients and clients, or people trying to help themselves that maybe have never been introduced to this. Well, you said something on your path that sort of is more interesting to me. We'll get to that in a little bit, just in case anyone at the end wants to keep listening. So would you say that because posture is something, right? Like you get on Instagram or you just Google good posture, bad posture. Like what, like in terms of, because this is obviously something that you've observed for a long time, you've done a lot more training in it. Do you feel like can you kind of describe how, it's really open-ended, but perhaps how you see good, is there a good versus bad posture versus maybe what your patients think good or bad posture is? Like when a patient comes in, they go like, oh, I have poor posture, or I have good posture. Do you think that the usual perception of what patients have when they come in, do you think that it's accurate, or can you kind of give an example of typically how they might see posture versus how you try to help them?
Loaded question, because there is no good posture. There is no bad posture. We need variability of movement. So I should get to this. I should get to this. I should be over here. I should be over there. So,
and just for people that can't see it at times, Teddy's sitting up very, very straight. He's bending over, and then he's leaning to the side, leaning to the other side, and saying that we should be able to get to all those positions, which I do 100% agree with, but I'm going to let him keep going.
I should be able to rotate to the left. I should be able to rotate to the right. We shouldn't be static. In today's society, sitting at computers, yeah, we are. But we need to be able to have that variability of movement. We need to be able to obtain all these positions. So when a patient comes in, They're always one of the two. They either say I have really bad posture, I know, or I think I have pretty good posture. There's never an in between. Someone that's like, I think I'm good. Sometimes, and sometimes not, which should be what they say.
Yeah.
So, because you're going to get in good positions, you're going to get in bad positions. So I kind of lost my train of thought.
No, you're good.
Basically, there is no good posture. There is a place we should be a good portion of the time, and then we should obtain all the other postures throughout the day. Okay. Our postures are extremely influential in more than just what our joints are doing. It's a stimulant and an inhibitor to our central nervous system. Certain postures cause us to inflate our lungs more. When I arch backwards, I have more air in my lungs, which is going to change the pH of my blood. It's going to stimulate my sympathetic nervous system, which is part of your central nervous system. That's the fight or flight. When a lion's chasing you, back when we were cave people, your sympathetic nervous system kicks in so you can run really fast. Now, when I'm sitting on the couch eating a bag of chips, binging on Netflix, I'm in my parasympathetic nervous system. So I am rest and digest. Most of my blood is going to my gut to help churn and digest food. And my muscles of my legs and my arms are significantly decreased with blood flow. And I'm in my parasympathetic. Throughout the day, back when we plowed fields and did a lot of manual labor versus more computer work like today, we alternated between those two systems all through the day. And that's what we should be doing. But most people that are coming in for pain tend to hold a sympathetic posture. They tend to be a little more arched. So their system is just going. I mean, how many of our patients do we see, or just your family members? They're like, oh yeah, I carry all my stress on my shoulders. Well, when you stand with an arch in your back, you sit with an arch in the back and you never touch the actual seat, or you sleep on your side or on your belly or on your back, but with an arch, you don't get that air out and get round. Your system's never shutting off. Your sympathetic system is through the roof. Your sympathetic system is through the roof. You're ready to run. Your upper traps are on. Your lower back muscles, called your paraspinals, are on. Your quadriceps are a little activated. Your gastrocs, fancy word for calves, are on. You're never shutting off. You're never resting. When you wake up and you sit up in bed and you feel stiff and you feel like you never slept, well, because you didn't. You were just running all night in your dreams. You need to chill out.
I like that. So it sounds like a lot of patients, like their perception of what good posture is to be in this sympathetic sort of position, really upright, shoulders back, back being, I'm gonna put in air quotes, like straight. Mostly because when we look at ourselves in the mirror, it seems that we look straight. Whereas I know usually when we actually get a picture, have a client look at themselves from the side, they're actually like arched backwards.
Mm-hmm.
Why? I mean, I have my theory, and I'll sort of give it. It's and I have many theories as to why this is, but there's obviously, like, I mean, if you just Google or go on to like social media for the most part and look up what good posture or good technique is, it's just plastered everywhere in terms of what is a good posture. And it's exactly what you were just saying, right? Where it's this arched back, this sympathetic nervous system, rib cage up, everything sort of being as erect as possible. And it's sort of difficult. So I was kind of, I didn't really know how this exercise would go. And so I don't think we're going to do it, but it's sort of an interesting idea, right? When patients come in, and they come in to see you, is if their life is plastered, their parents have told them their whole life they need to sit up straight and put their shoulders back, they need to be upright and be tall. How do you go about sort of having that conversation with people at first? And I know it's different probably for each person, but how do you go about introducing like this concept that being upright and having your shoulders back and being as tall as you can all the time is while they're coming in and people are usually doing that, and they're sort of stuck in that position, how do you sort of talk them in, or sort of shift the perspective that being in that position all the time is maybe not the most ideal for their health and their pain control? Um, like, is there any sort of like icebreakers, or their exercises, or like is there any way that you sort of talk, and maybe it's just what you just said in terms of like you need to be able to do all these things. So maybe, for example, someone comes in, they're the type of patient that says, you know, I have really, really good posture, and you look at them and everything is sort of jammed in. They're, they're super upright. How do you go about sort of conversing with that person that, you know, without butting heads and sort of doing this aspect, like what might be one takeaway from that day? And you can give 2 or 3 takeaways, I don't care, but in terms of like, if there's one thing they could leave with that session to sort of extrapolate on outside of the clinic, like what do you sort of bring up to them?
So it's going to depend on the patient and their, and if they have a knowledge of anatomy and physiology, it makes it easier because I can be more specific. But in general, I basically give a lighter summary of kind of what I just talked about prior. And if I start seeing them get kind of glazed over, going above their head, then I back off of it, use different terms. I like to use a lot of analogies. And so I try to use that. But the biggest thing is, I'd say 9 times out of 10, at the first initial assessment, I do my assessment. And then when I'm telling them what's wrong and what's going on, and typically this posture comes into it, I'll give them that little bit of a summary, and then I'll actually show them. And I won't do any exercises the first visit. I'd say 10% of the time I do exercises the first visit. I will show them how to stand, how to sit, and how to sleep on the first visit. I always go over those because I could give the patient an hour worth of exercises to do every day. And for that hour, they're going to be awesome. And then for a little bit after. But then when they go sit at their desk in that terrible posture, I just said previous, there is no good posture, but you know what I'm saying. When they sit in a static, bad place for a long time, their pain comes right back. Like, all these exercises aren't working. Well, no, when you did the exercise, you felt great. But realistically, you can't be doing them all day. So we need to change how you're sitting. We need to change how you're standing. We need to change how you're sleeping. So that first visit, to really get, I hate to say like buy-in, like I'm selling something, but to get them to feel the difference and really be like, holy cow, there is something to this. He's not just making this stuff up using crazy science words. I will have them stand how they normally stand. Of course, I'm assessing it. And then I'll exaggerate what they're doing. And then I'll exaggerate to the opposite side. And then I'll settle them somewhere in the middle. And they're like really trying to think about what I'm doing, having them do it. And then they're doing it. I can see they're really focused. Then I go, hey, how's your back feel? I'm a bit, someone coming in back pain all the time. How's your back feel? Oh man, it doesn't hurt. I'll go, good. That's why we need to do this. I'll do the same thing. I'll throw a pillow on the table, say, all right, hop up on the treatment table, lay how you lay normally to sleep. And they'll be in it. And I'm like, okay, how's your back? It's pulling and it's a little tight like it normally is in this right side. I'm like, okay, situate them, get those ribs down, get them in a more neutral position versus that extended position. Same thing. I'll be like, how's this? So reply is almost always, this is so comfortable. And I'll go, and how's your back feel? Oh man, it doesn't hurt again. Awesome. So this is what we're going to do. And then the same thing with sitting. The sitting is always very interesting to me because when I have someone sit, like, oh yeah, I feel it, their pain. And then I adjust them and show them a better place to get to. And their eyes are always like, oh man, I feel the back of the chair on my lower back. And I go, yeah, you should, every time. It always blows people away how much they're pulling away from the chair. And just those 3 things I give the first visit, also explaining what I think's going on pathologically and whatever they're there for, and send them away with a handout that I always have pre-written, print off for everybody, and alter, because not everyone's the same, but alter it, print it off for them, and send them home. And then most of the time they come back for their second visit. I'm like, how's your pain? It's never gone, but it's always like, man, it was constant nagging 2 out of 3 pain all the time. And now there's times when I don't have pain. I'm like, good, we need to keep doing this, because you sleep for 6 to 8 hours. You're standing a good part of your day, and you're sitting a whole boatload of your day, or sitting in the car, sitting at your desk, whatever, sitting at the dinner table. If we don't change those 3 things, 22 and a half, 23 hours of the day, you're, unbeknownst to yourself, hurting yourself. Okay. You're not necessarily injuring yourself further. But if I had a bruise on my arm and I just lightly press my thumb into that bruise for 23 hours, I'm not going to expect that bruise to be better the next day. It's going to remain the same, or it's going to get worse. So that's what I do. Again, long-winded, sorry. Obviously, I'm an introvert and hate talking. Sarcasm. So they need to change how they're moving through the day, sitting through the day, sleeping through the day. So that's what I do first day to get them to be like, oh yeah, okay. I thought I had good posture. I was trying to be too good with my posture, bending back or arching backwards. I need to get a little air out of those lungs. Let those ribs drop towards my own spine, which engages my abdomen. Everyone knows we need more core work, right? But what does that mean? Do I flex my belly like I'm at the beach and, don't want to look bad? No, that's not going to get you anywhere. That's going to flex the six-pack muscles, your rectus abdominis. It's not going to engage your transverse abdominis, your internal obliques, external obliques. That's what we need. It's not going to raise that diaphragm up. The diaphragm is your breathing muscle. Should be this dome-shaped muscle at rest. But if I'm in a flared up position, that dome is going to drop some. It's going to drop even more because of my internal organs, which maybe we'll get to, maybe we won't, might be a little too heavy for this intro podcast. But if that is dropped, my ribs are going to flare more. And I'm going to be now in a relaxed position into this extension bent backwards. And now it's going to be hard to get out of it. I need to get those abdominal muscles we just talked about on. I think the reason we sit into this most often is, one, we're told shoulders back, proud chest, head tall, all that. But also, it takes way less calories to hold that position. It takes the lower back muscles to be on to get me there. But once I'm there, they can be minimally on. And now I can sit on those spiky bones that stick off the spine. I can sit into those facet joints, technically, zygapophyseal joints. But if anyone listens to this one is on Jeopardy, they better get that question right. So now I'm sitting into those joints. My abs are off. I don't have to do anything. And I think that's why everyone goes there. I think we're innately lazy. When we were cave people, didn't know what our next meal was. I'm not going to stand up, engage my abs, and burn calories. Might be another 3 days till I eat. I'm going to just go here and hang out.
Fantastic point. Yeah, absolutely. Finding the most efficient way to be upright is where the body's always going to go to. That's a great point. Whether it's our body or it's even our heads and our minds, right? We're always searching for an efficient way to do things. Well, at least I am. I guess if we're not, it's I guess I should.
I've known you for a long time.
Yeah.
Sometimes it seems like you're taking the long route.
It's but you got to fail enough times to realize you were wrong long enough to realize you could have done it faster. But that's kind of what wisdom is, right?
Yeah, isn't it Steve Jobs that said if he ever wants to find the fastest way to do something, he'll give it to the employee that knows the littlest about it, because they're his. I think he used the word laziest employee, because they will find the fastest way to get it done. If you give it to your smartest, deepest thinker, they're gonna make it super complicated, super well done, but it's gonna take 2 weeks to do it. Versus the lazy guy who's like, man, I think I can do this in 2 hours if I do it this way.
It's a great point. I've got one other question for you. Is, let's say someone I'm going to give an example as far away from the back and the rib cage and the hips and the hip joints as possible. So let's go like finger pain, like thumb pain and or big toe pain. Okay. Someone's coming in with that stuff. Would you still do this?
100%.
Okay.
100%. So let's, do you want to go into it?
I mean, I 100% agree with you, but yeah, absolutely. I would love you to explain your
yes to both.
Your idea on it.
Yes to both, but for different reasons.
Yeah, let's talk about the toe.
Okay, I was already ready to go to thumb, but we'll go toe. So someone's coming in with toe pain and they're sitting wrong, they're sleeping wrong, they're standing wrong. Okay, so they're in that, let's say, extended position backwards. You will get patients that aren't, but most are. So I'm in that extended position all day long. When I stand up to now walk, and every time I step forward and that foot goes behind me that has a hurt toe, it hurts. Okay. Why is my posture affected? If I'm in this extended position all the time, I'm going to have all the muscles in my back be in a shortened position 99% of the time. So what's the likelihood that I suddenly stand up, get into a good position, and walk? It's very low. So when I'm in this extended position, it's going to take my pelvis. So think of your pelvis, think of a skeleton. Think of it like a bowl, okay? Then you have your rib cage, picture skeleton. It's like a hollow bell, okay? And they're connected by the spine. If I am living in this extended backwards position, okay, that bowl is going to tip forward and that bell is going to rock up, all right? Now, my hips plug into this pelvis. If I'm supposed to plug in like this to my pelvis, here's one leg, let's say right in this case. If this is tipped forward, all the muscles of my hip that come from this pelvis over to this leg are going to be at a different position, okay? If I take a 5-pound weight and I curl it, it's easy. If I take a 5-pound weight out like this and try to curl it, it's harder, okay? So if I take this pelvis and tip it and lengthen some muscles or change the angle they pull at, now it's going to be harder to control that hip. So now when I'm walking and I step and I try to progress forward, let's say this is the leg that has the hurt toe. If I try to come forward, I can't because I already have muscles that are stretched out because that pelvis is tipped forward and I got an arch on my back. So my hip is going to stop. I can't progress forward on my hip as I should. So now something's got to give. My knee can't hyperextend backwards and allow for it. So I don't know if you're going to be able to see it. I'll stand on the table.
Lovely.
We're
about to see a workers' comp injury right here. This is great.
Hey, I'll take 2/3 pay. So if I come forward and now this hip locks up and I try to come forward, something's got to give. I'm nervous. That toe is going to extend. It's going to bend excessively to make up for the lack of hip motion. It's way more complex than that. There's other stuff going on too, but I'm just trying to make a generalization. So that's why this extended posture affects my toe in a short, easy, without getting super complicated and examining someone way. When it comes to the thumb, is that good enough for the tail?
Yeah.
Okay.
Oh, no, you're good. So let's hear the thumb. I love it.
So now the thumb, I don't walk on my hands. Well, that's not true. I do occasionally show it to patients. But if I'm having thumb pain and I'm whatever activity it is I'm doing, I don't know, turning a screwdriver and it hurts my thumb. If I'm in this extended position, the same way the hip was affected by that pelvis being tipped forward and changing the orientation of all the muscles, the joint, everything, that's going to happen in the shoulder via the rib cage. Because if that rib cage is flared up, it's going to change the joint of my shoulder, where my arm plugs in. It's a ball and socket joint too, just like my hip was. You have your hip and the femur, the thigh bone, plugs into it. In the shoulder, same deal, different mechanically because the socket is much shallower. It's more like a golf ball on a golf tee, so it's a little more unstable. But regardless, if I'm arched like this, now my shoulder is at a disadvantage. The muscles are at a disadvantage. The joints not in great alignment. The ligaments, tendons, capsule, all that. Tension in some spots, too loose in others. So now when I'm reaching out to use that screwdriver, I'm not as efficient at using my shoulder for what it's supposed to do. The point of my shoulder is to get my arm where it needs to be so that my elbow can position my hand in a place where I can do something with my fingers and wrists. That is what the arm does. The shoulder just gets you there. Elbow positions you into the small little position you need to be to then use your hand. But if I'm in a bad position, I can't use my shoulder as well. When I come up like this, I get this like little pain in the end of my shoulder. So I'm going to do a little less of that. And now my elbow can't get me where I need to be so much. So I'm going to compensate and use my wrist and fingers more. And if I do that, I just change a light bulb. I do it once. Yeah, sure. Fine. But if I'm an electrician or a mechanic and I'm using tools all day, eventually something's going to give. You're using something way more than you should. And in this case, it would be the thumb.
Yeah. It's always sort of an interesting conversation when people are like, well, I've always done it this way. I'm like, well,
that's the problem.
Things are good until they're not good. I don't know what else to say. That's sort of pain.
I don't know why, but every time I hear that, well, this is the way I've always done it. I always think of people with neck pain that are belly sleepers. And You got to stop sleeping on your stomach. And I'll start going over a position. Like, yeah, but I've always done it this way. And it's always comfortable. I'm like, okay, you have neck pain. What I want, and how long do you sleep? Oh, 8 hours. Okay, great. Tomorrow at work for 8 hours, I want you to sit at your desk, move your computer 90 degrees to the right and work like this all day. You're looking at your screen to the right. Like, no way, that'll kill my neck. And I go, okay, when you're sleeping on your belly, do you sleep face down and suffocate? Like, no, I turn my head to the side. I go, for 8 hours? And they're like, oh, that always really brings it home. Like, oh, I might as well be sitting on my desk like this. I can't sleep on my stomach anymore.
Love it.
But
Love
sorry,
it.
that just popped into my head with what you said.
No, it's perfect. That analogy I think is easier and quicker than usually the ones I go for that one. So I'm gonna steal that one for sure.
Oh, you better give me proprietary rights on that. I want royalty checks every month.
Yeah, well then I'll tell him Edward S. Greeley the second. Excuse me. This is I have to give him. You have to give him a call in case you have any questions about this. All right, Ted, this has been a fantastic conversation. I hope listeners or or any of viewers they have any questions about this. Feel free to reach out to Ted at the Riverview Physical Therapy. He's at the Portland Clinic, but online you should be able to find
Portland, Maine, not Portland, Oregon.
Sorry, yes, Portland, Maine. For everyone around the world that's watching this.
For all our international subscribers.
And I know I forgot to break for our paid advertisement, but you know.
But what is it they say on YouTube? Don't forget to subscribe and hit that like button.
Yeah, or hit that bell if you're
go on notifications.
Yeah, hit something there. But in any case, or also feel to reach out to me, Cameron at performancetherapyinstitute.com, or check out the website at performancetherapyinstitute.com. So I'm starting a new physical therapy clinic in Bangor, Maine. Definitely check us out. But in any case, if you do have any questions, hopefully this was helpful. We can obviously expand or slow any of this stuff down in the future, as I'm sure Ted will be on in the future as well as we move forward. Ted, anything else you wanted to add?
No, it was fun. I enjoyed it.
Yeah, this is a great time.